Welcome back to the Pulmonary Perspective. Today, I want to talk about one of the most common and honestly one of the most frustrating symptoms that we encounter in outpatient pulmonary medicine, and that is chronic cough. One thing I've learned over time is that cough can sometimes seem deceptively simple at first. Patients often come in thinking maybe they just have allergies or a lingering infection, but occasionally chronic cough can actually be the first clue to something much more significant happening underneath the surface. And interestingly, some of the patients with the most persistent cough can initially have relatively normal vital signs, relatively benign physical exams, and even fairly normal baseline testing. So the key in outpatient pulmonary medicine is learning how to think through cough systematically. When you hear the term chronic cough, what diagnoses immediately come to mind for you? And for those of you working in healthcare, what do you think is the most commonly missed contributor to chronic cough in the outpatient setting? Let me know down in the comments because I'm always interested hearing how different providers approach these patients. When we talk about chronic cough, we're generally referring to a cough that has persisted for more than 8 weeks. And while there are many possible contributors, I often tell patients there are 3 major causes that account for a large percentage of chronic cough cases in outpatient medicine. Those include upper airway cough syndrome, usually related to postnasal drainage, gastroesophageal reflux disease or acid reflux, and bronchial inflammation, most commonly asthma or cough variant asthma. Now, of course, pulmonary medicine is rarely quite that simple, and many patients actually have overlap between multiple causes occurring simultaneously. The first thing I focus on is the history, because in pulmonary medicine, the history often tells you where to start looking before you ever obtain testing. I want to know whether the patient smokes or previously smoked. How long did they smoke? How much did they smoke? Do they currently vape or use inhalational substances? Tobacco exposure can contribute to chronic bronchitis, emphysema, airway inflammation, and malignancy. I also ask about occupational exposures because sometimes patients do not realize how relevant those exposures can be. Have they worked around silica, welding fumes, dust, chemicals, asbestos, agricultural environments, or industrial irritants? Occasionally, chronic cough can be the first manifestation of environmental or occupational lung disease. Then I start focusing more specifically on the characteristics of the cough itself. Is it dry or productive? Are they bringing up sputum? Do they wheeze? Do they experience chest tightness or shortness of breath? Are symptoms worse at night? Does exertion trigger symptoms? Do they wake from sleep coughing? Do cold air or respiratory infections worsen symptoms? One thing you learn quickly in pulmonary medicine is that symptom patterns matter tremendously. For example, if someone describes intermittent wheezing, nighttime cough, chest tightness, or symptoms triggered by cold air or upper respiratory infections, then asthma or cough variant asthma immediately rises higher on my differential diagnosis. On the other hand, if someone tells me they constantly feel drainage in the back of their throat, frequently clear their throat, have chronic sinus congestion, seasonal allergies, or a sensation of mucus dripping posteriorly, then upper airway cough syndrome becomes very likely. And reflux can sometimes be surprisingly subtle. Not every patient with reflux-related cough has dramatic heartburn symptoms. Some patients primarily present with chronic cough, hoarseness, throat irritation, globus sensation, or frequent throat clearing. Medication review is also extremely important because medication-induced cough can easily be overlooked. ACE inhibitors such as lisinopril are a classic example. If I see a patient is taking an ACE inhibitor, that immediately gets my attention because ACE inhibitor-induced cough is actually very common and often under-recognized. Sometimes patients have tolerated the medication for months before the cough becomes problematic, so the timing is not always obvious. After obtaining a detailed history and performing a physical examination, I typically start with baseline testing, including a chest X-ray and pulmonary function testing. I think baseline imaging is important because parenchymal lung disease can occasionally present subtly. Even patients who initially appear relatively stable clinically can sometimes have underlying abnormalities that contribute to cough. And honestly, Some of the sickest pulmonary patients I've seen initially presented with nothing more than persistent cough. If I obtain a chest x-ray and start seeing subtle reticular changes, scarring, hyperinflation, nodularity, or other parenchymal abnormalities, then my differential diagnosis immediately broadens. At that point, I may begin thinking more heavily about smoking-related lung disease, interstitial lung disease, pulmonary fibrosis, chronic infection, or other structural pulmonary pathology. And if those findings are subtle or unclear, then obtaining a high-resolution CT scan can become extremely valuable because CT imaging allows us to evaluate the lung parenchyma in much greater detail than standard radiography. Pulmonary function testing is also incredibly important because it helps us evaluate physiology rather than just anatomy. If pulmonary function testing demonstrates obstruction, then we start asking ourselves whether this appears more consistent with asthma, COPD, small airway disease, or overlap physiology. If I see bronchodilator responsiveness or reversibility after administration of a bronchodilator, that significantly increases my suspicion for asthma or airway hyperreactivity. Sometimes spirometry may initially look relatively normal, but there may still be subtle evidence suggesting airway inflammation clinically. And interestingly, some patients with cough variant asthma may not have dramatic wheezing or obvious dyspnea. The cough itself may actually be their primary manifestation. If I instead see restriction or a reduced diffusion capacity, then pulmonary vascular disease or interstitial lung disease may enter the differential diagnosis more strongly depending on the clinical picture and imaging findings. And this is where pulmonary medicine becomes very analytical because we are constantly integrating symptoms, physiology, imaging findings, exposures, and response to therapy together. Now, one thing that is extremely important is recognizing when the history suggests something beyond the common causes of chronic cough. For example, if a patient has significant sputum production, recurrent bronchitis, recurrent pneumonia, chronic congestion, or daily mucus production, then bronchiectasis becomes something I strongly consider. Sometimes patients describe years of recurrent respiratory infections or explain that they are always congested. Others may report chronic productive cough every morning for years. If symptoms seem disproportionate to the chest x-ray findings, or if clinical suspicion remains high, then CT imaging becomes very important because mild bronchiectatic change can easily be missed on routine chest radiographs. Smoking-related chronic bronchitis is another extremely common contributor to cough. Many patients normalize their symptoms because they have been coughing for years, but chronic airway inflammation from smoking can absolutely drive persistent cough and mucus production. We also think about eosinophilic airway disease, aspiration, chronic infections, vocal cord dysfunction, medication effects, pulmonary malignancy, and interstitial lung disease depending on the patient's risk factors and overall presentation. Another major point I always try to emphasize is that chronic cough is frequently multifactorial. It is incredibly common for someone to simultaneously have reflux, allergic rhinitis, and airway inflammation all contributing together. And honestly, that overlap is one of the reasons chronic cough can become so frustrating for both patients and providers. Sometimes improvement requires addressing several contributors simultaneously rather than searching for a single isolated diagnosis. Another important question becomes determining when additional workup is necessary. Not every patient with chronic cough requires extensive testing immediately. In many outpatient cases, we often begin by addressing the most common causes first, while simultaneously looking for red flags that would prompt more aggressive evaluation. For example, if someone has hemoptysis, progressive dyspnea, unexplained weight loss, recurrent pneumonia, hypoxemia, substantial smoking history, abnormal imaging, or constitutional symptoms, then obviously the threshold for obtaining advanced imaging and more comprehensive evaluation becomes much lower. And this is really what outpatient pulmonary medicine is about. It is not simply memorizing diagnoses. It is learning how to recognize patterns, identify risk factors, interpret testing appropriately, and determine what the next best step should be for that individual patient. I also think reassurance and education are incredibly important because chronic cough can significantly impact quality of life. Patients may struggle with sleep disruption, fatigue, embarrassment in social settings, throat irritation, chest discomfort, anxiety, and frustration after seeing multiple providers without clear answers. Taking a thoughtful and systematic approach helps both the provider and the patient move through the diagnostic process more efficiently and confidently. One thing I'd actually love to hear from you in the comments is this. For those of you working in medicine, what do you personally think is the most commonly overlooked cause of chronic cough in the outpatient setting? And for everyone else watching, what pulmonary or sleep medicine topic would you like covered in future videos? I hope this video helped provide a practical and evidence-based overview of how I generally approach chronic cough in outpatient pulmonary medicine. Future videos are going to focus on pulmonary function test interpretation, pulmonary hypertension, sleep apnea, interstitial lung disease, imaging interpretation, hypoxia, and additional real-world outpatient pulmonary reasoning. Thanks again for watching The Pulmonary Perspective, and I'll see you in the next video.